There are a couple of studies going in that direction where people have looked at various combinations. And there's a study done by the GOG, now called NRG, which was intraperitoneal patients who were platinum resistant, got intraperitoneal carboplatin with intraperitoneal bortezomib. Now, bortezomib is a proteasome inhibitor. It interferes with the degradation of the transporter. When platinum hits the transporter, it gets internalized, it gets degraded, and no more platinum gets transported in. So if you interfere with that transport degradation, you keep transporting platinum, and that was the hypothesis. And sure enough, in this study done, small study of 20 patients or so, there were quite a few responses in this particular protocol. There's also the combination of PARP inhibitor, which you allude to, and it's in combination with intraperitoneal fluorodeoxyuridine, which is a drug that has no advantage over fluorouracil given intravenously, but given intraperitoneally has quite dramatic advantages. While this particular drug, when combined with a PARP inhibitor, gives a very robust increase in effects, anti-tumor effects in preclinical studies, and there's a pilot study ongoing at the Mayo Clinic with this particular combination. And so the intraperitoneal route lends itself for retreatment of ovarian cancer when it recurs in the peritoneal cavity. It gives the opportunity to do some modulation by various means, introducing new compounds. So if you're not doing the first-line studies, you lose out because people won't have these catheters placed. The knowledge of handling the patients for intraperitoneal chemotherapy, which exists now, would disappear. So those are not a downside to this last study, which people are quite anxious about. How do we proceed?